So next I think we have Dr. Rob. And what Dr. Rob is doing is the genetics talk, but then we ask him to talk about neurology also because we don't have a neurologist here this year. Thank you, Dr. Rob. You're up.
It's good to be here. I look forward to this meeting every year and plan to keep coming for as long as we have the meeting or until I can't anymore. What Jerry said about going back to your own doctors is really important. What we're talking about when we're up here is the general picture, and your specific needs may be different than that because there are other factors that need to be weighed in. So sometimes we will say, and we never do this, only sometimes we do. And so just make sure you talk to the doctors who are actually involved in your care because they will tailor it to your specific needs. All right, disclosures. I will talk to anybody about Fabry disease at any time. So this is a very simplified version of what is Fabry disease. So mutations in the GLA gene, that means that alpha-galactosidase A, the enzyme that's supposed to do the work, either doesn't get made at all, or gets made but doesn't work, or just too little of it is made. That results in lack of breakdown of GL3, which builds up in the lysosomes, and for a number of different reasons that stresses the cells, and the cells don't do their jobs right, and that leads to the damage to the organs, that leads to Fabry disease. So, now, Fabry disease, we talk about the organs in the body like they are the only ones. So the cardiologists talk about the heart, the nephrologists talk about the kidneys, but that's not how it works. The storage is taking place throughout your body, and damage is being done a little bit everywhere. The ones that we emphasize most are either the ones that are most likely to have life-threatening complications or that have other functional impacts that the patients have reported to us. So if you notice something and you don't know if it's related to Fabry disease, mentioning it to your doctor could be a service to the rest of the community. So I would encourage you to do that. I know that several of the things that I have been involved with, the questions were brought to us by patients. And we're like, oh, never thought of that before. So lymphedema was one of those. But as you can see on this slide, lots of parts of the body are involved. And it's multiple cell types in each body part. I'm not going to go through all of them because I don't have enough time for this talk. But multiple systems in the body. So we divide Fabry disease into two broad categories. First one, which is severe, is referred to as classical Fabry disease. It's usually less than 1% of the expected amount of enzyme activity. This one usually presents in childhood, usually involves multiple body systems in an obvious way. So people will have pain, hearing problems, GI problems, kidney problems, heart problems, all of the above. And it's slowly progressive, but definitely progresses. Both men and women are affected. And the order in which the individual symptoms come up varies between people, even within the same family, but most people will have a broad spectrum of impacts. The other group is partial loss of the alpha-galactosidase A enzyme. It's referred to non-classical. There's also a whole bunch of other ways people refer to it. I like non-classical best. because that leaves open the idea that it is in fact still a life-threatening disease and it's still progressive, so saying mild doesn't seem right. Attenuated is just a big awkward word that means a little bit different. And then the other things that people will sometimes say is, you have cardiac Fabry disease, but if you do biopsies, you don't ever just have cardiac Fabry disease, or at least very rarely, and kidney disease the same way. You have storage going on in more than one part of the body, so not accurate. Usually this is between 3 and 30%, and the more enzyme deficient, the worse your enzyme deficiency, the more rapidly the disease progresses, but it doesn't always correspond completely. Many times there is only one organ that is obviously involved. Most frequently that is the heart. Sometimes it's the kidneys, sometimes other things. But part of that is that we haven't really looked carefully at non-classical Fabry disease. There are a grand total of 0 papers looking comprehensively and longitudinally at that group. And that means that we're kind of making stuff up when we talk about it. So we need those formal studies to be done to really find out the natural history. The problem is that you'd need 10 years of follow-up, and 10 years is a long time. Collecting that data, cleaning it up, analyzing it, and then figuring out what that means is a big investment, and so far nobody has done that. This one often lacks GI disease, may lack the corneal whorls or any other eye findings, but may have heart, kidney, cerebrovascular, hearing loss, fatigue, etc. But we don't know what percentage of people will manifest each of those at this point. Not a lot of physical findings in Fabry disease. So these are pictures. The two on top of each other are showing angiokeratomas. The ones on that hand are pretty easy to see, but only if you look at the palms of the hands. And not everybody has those lesions on their hands. The ones on that belly button can really easily be overlooked, and even fewer people look at belly buttons than hands. So don't be surprised if your doctor misses that. Now, I picked those pictures because they are subtle. There are people who are just covered with purple spots. Nobody misses those, but when they're that blatant, it's kind of a little too late, and it's not as easy to miss, but not also as helpful. Do you have a question? Yeah. So, and that one is again, these are findings that are really easy to miss. You can see the white streaks in the eye on that picture, and those are pretty easy to see, but what isn't obvious is that you have to be using a special piece of equipment called a slit lamp to be able to see those, and only ophthalmologists have those, and they don't use them as a routine part of every eye exam. So again, really easy to miss that. The other thing you can see on that eye, if you look at the white part of the eye, there are some blood vessels that are crooked and that are dilated more than the other ones. So you see some thin red lines on that. Then you see a couple of thicker red lines, and they have more twists and turns. That's called ectasia, the thicker, and the turning and twisting and turning of the blood vessels is tortuosity. And then in the lower part at about, I don't know, anyway, the lower left-hand side of the picture, there is a bigger purple spot. That actually is an important finding because that tells you that that blood vessel has some significant damage. And we think that the blood vessels in the rest of the body would be similarly involved, and that could be a risk factor for stroke or for decreased perfusion of the tissues where those events occur. So you want to pay attention to that stuff. Fabry disease decreases life expectancy. The red on here is people with Fabry disease. The green is people from the general population. You'll notice that the numbers are quite different, particularly for the men. Now, the two numbers are two different studies. So you can see that there was some variability. We don't know exactly what caused that variability. Both of the studies listed in this one were published in 2009. The data was collected over longer periods of time. Previous to these studies, there was another study done that was before there were any treatments available, and the numbers were even lower, where the general population numbers really haven't changed much in that period of time. So this is an important factor to keep in mind. Nobody has done a very recent study, but we have done some analyses on event rates, which means major, potentially life-threatening complications of Fabry disease, and shown that they are decreased with treatment. And in fact, there's a lot of reasons people choose not to be treated for Fabry disease or to be treated for Fabry disease. There's been a couple of studies recently looking at changes or at event rates. One of the reasons that people will choose not to be treated is because they feel like their disease is pretty mild, it's not really interfering with their life. So the untreated population is selected to some extent for milder disease, but the untreated population has far more major events. Yes.
So I don't want to make this about me, but I want to take the opportunity to say that if we, not always, but we have a chance if we do all the right things. I switched to the other side. I'm 71 next month.
So he's comparable to the general population.
Yeah, including a heart transplant, lots of things, but it's possible. So we can switch sides if we're lucky and if we do all the right things.
Right. So the goal for treatment in my mind is that the people that I treat will have the same life expectancy and the same quality of life as the general population. For the life expectancy in Fabry disease, we are actually getting a lot closer. I think if we did a study like the ones that these data were pulled from, it would look better now from a life expectancy. We have a ways to go on the quality of life still. Okay, so symptoms. Now we're going to focus. The next section of this talk is going to focus a lot on the neurologic aspects. So the first neurologic thing that we're going to talk about is pain. Pain is one of the earliest symptoms. In classical Fabry disease, you will see pain in most of the patients by age 5 or 6, and sometimes as early as age 2, maybe even before that. Much before that, it's hard to tell because babies don't say, I'm having pain. They just cry a lot, and you sort of have to guess what's going on. The pain, my patients, again, this has not been really well delineated, but my patients have told me very strongly that they think they have more than one kind of pain. Two of the kinds make a lot of sense to me, and I'll talk about them, and then some people think that there are more types of pain than that, but I don't have a clear enough picture in my head to talk about it. So chronic pain is one of the categories. That's a daily or nearly daily consistent pain. It's a nagging pain, and sometimes it's more of an abnormal sensation than pain. Sometimes it's pain, just pain. That can be deep. It can be burning pain on the surface of the hands. It's generally quite common with an occasional day without pain. And it bothers people, but it's not as bad as crisis pain. Now, my patients have told me that they think that not only is the crisis pain more severe, like to the point that they can't function with it, but it feels different. I don't know if that is true. I don't know what it feels like because I haven't had it. And I don't know whether there is physiology that could be measured that would be different between the two kinds of pain. I do know that the things that we would look for to look at nerve functions, like EMGs, typically do not pick up abnormalities in this kind of pain, in either of these kinds of pain, actually. The crisis pain is quite intense. It is often triggered by things like an illness, particularly fever. Stress or fatigue can induce it. Increased physical activity can induce it. But it also happens without any obvious triggers. And so nothing identifiable can be said to be the consistent cause. This starts again as early as age 2, maybe before that, but the babies can't really tell us. So how often does this pain occur? Because everybody experiences some pain, and in fact, you do not want to be somebody who cannot have pain. That's a bad thing. But you also don't want pain that's severe enough to interfere with your life. This is data from a study of school-aged children, and in that study, we looked at people in the general population, and about 5% of kids will complain of pain on a somewhat frequent basis. So they qualify it as having this finding. The other group, the people with Fabry disease, that's more than 40% of the patients had a somewhat consistent complaint of pain. That's a lot. And the pain is bad enough that it interferes with school function, leads to missed days of school. So in childhood, when I started working with Fabry disease, I was told that it is an X-linked disease that is primarily adult, primarily male, and primarily kidney, with pain and heart disease as secondary findings. All of that was wrong. It's a childhood onset disease. It affects men and women. Well, actually, the X-linked part was right. The rest of it was wrong. It is as much heart as kidney, for both men and women, more heart than kidney for the women. So there were a lot of things we didn't know. And we're getting better at that. We learned that because patients came in and said, I think you've got this wrong. So speak up. Females with neuropathic pain, if you go into adulthood for classical Fabry disease, over 70% had moderate severe pain, and 50% of the women reported frequent pain. So it's not just a once or twice a year kind of thing, it's a fairly consistent problem. Now, comparing that to the general population, females in the general population do have pain. Some of them have chronic pain and crisis pain, and that's 7 to 25%. It's a lot less than 77%. Now, I did not pull those numbers for men. They're even higher for men. But I think one of the important things is that both men and women, pain is a significant burden of the disease. So how do we treat it? What do we do? The Fabry-targeted drugs that we have right now that decrease the storage in the cells in your body do not get great penetration into the nervous system. So we don't just see the pain disappear with any of the current treatments. But there are other treatments that can help with the pain. The most common group are neuroleptics. This is a group of drugs that were invented for seizures. This isn't because we think the pain is related to seizures or because we think people with Fabry disease have seizures. Anti-seizure drugs stabilize nerve cells. Pain is caused by abnormal triggering of nerve cells. So we thought, well, maybe if we stabilize these nerve cells, that will help. And for at least some things it does. So there's a list of drugs on there. There are some additional neuroleptics that have been used, and they stabilize nerves, not all in exactly the same way, but that decreases the excessive triggering, and that helps with many people to decrease the pain. Antidepressants are also used, and there are some listed on the slide. There are others that can be used, and they stabilize the nerve cells as well in a different way so that you can use a neuroleptic and an antidepressant. It's not just the same as just increasing the dose. So using more than one kind of medicine can be an effective strategy. The downside of using these medicines is that all of them have some sedating effect and sometimes can make it hard to focus or to get things done. And I don't know about you, but I personally can't use any more distractions or fatigue in my life. There are some other ones, lidocaine, capsaicin, cannabinoids, etc., that can be used. And there are some crisis-only categories of drugs that can be used. And the one that's on here that strikes me as making no sense at all, but somebody tried it and it worked, at least for some people, is capsaicin. Capsaicin is the oil that makes hot peppers burn your tongue. So somebody who had burning pain in their hands and feet thought, I have burning pain in my hands and feet. I think I'll put this stuff that makes my tongue burn on my hands and feet and see if that helps. But it did.
Isn't that a distraction pain reliever?
The thought is that it is a distraction pain reliever. What it does is confuse the individual nerve cells so that they forget that they're supposed to fire or that they're about to fire and then they don't. And so we think that that's the mechanism for it working. In any case, for some people it does work. Other people have told me it just made their pain worse. So if something doesn't work, tell your doctors that it's not working and don't keep doing it if it's making it worse. But sometimes things that sound crazy actually are useful. Another example of that is the first effective treatment for malaria was actually a pharmacist ran out of an ingredient. In those days they used bark. tree bark as one of the major ingredients in drugs. He ran out of the bark of the tree that was supposed to treat malaria that didn't work. And he found another tree that looked kind of the same and grabbed a bunch of bark and made a tea with it and told people to take that. And they kept coming back wanting more. And he's like, well, I'm just going to sell more of this. But it turned out to work. It was the first truly effective treatment for that. Okay, so the other major neurologic complication of Fabry disease is stroke. And cerebrovascular disease has, so in the study that's highlighted here, 135 patients were studied for stroke, and 52% of the males, 40% of the females eventually had a stroke. Average age for the males was 39, for the females was 46. The bottom line is from a different study, and that one says that 2/3 of the males who had had a stroke and 40% of the females who had had a stroke had the stroke before they learned that they had Fabry disease. So strokes are an important life-threatening cause. Strokes are hard to deal with in some ways because you don't get much warning for a stroke. So for females, this is a different study. Only 25% in this study had strokes, but the age of onset was quite early. And in Fabry disease, just across the board, well, for females, the median age it's a different study than the one at the top, for stroke was 45 years. For TIAs was 43 years. That means that TIAs come first in many cases and gives us an opportunity to intervene to try to prevent stroke, but only if you tell your doctor about the TIA. So please do that. Now, another thing that we hear a lot is that the strokes are only due to the heart disease or sometimes the kidney disease, particularly atrial fibrillation. Don't believe that. Some of your doctors might tell you that. The data does not support it. So in the studies that have been done, more than 3/4 of the patients who had a stroke had their first stroke before they had a renal or cardiac event, before they had renal insufficiency or heart failure. Now, we've been talking pretty high numbers for stroke. Let's compare that to the general population. In women, less than 3% have strokes, and those are mostly over age 75. The strokes we're talking about are in the 30s, 40s, 50s, and a lot more than 3%. This is another way of looking at that. The top line is men. The next line down is women with Fabry disease. The bottom two lines are the general population. One of the things that's obvious on this slide is that one of the key risk factors for a stroke is age. And that's true for men and women with Fabry disease and in the general population. The older you get, the more you need to be aware of strokes. So treatments for strokes. There has been a lot of controversy. This is an unpublished study that I took notes at the last World meeting, so I did not get permission from the Dr. Berlina or from Sanofi, who sponsored the study, but I did take notes, and it's accurate. And actually, I did previously ask them if I could talk about this, but it's unpublished. They got a large number of patients, and to be enrolled and included in this study, they had to have not had a stroke at the time that they started collecting the data, and they counted the number of strokes and calculated the strokes per 1,000 patient years. For people with Fabry disease on treatment, that was 5.5 strokes per 1,000 patient years, which is still a pretty high number, but it's a lot better than the untreated. Now remember that I already mentioned that untreated are selected to be a little bit milder disease, but they had twice as many strokes. So being treated is good. Do not defer treatment because you want to get to a certain age before you admit that you have something. You get more benefit out of being treated if you get treated. Fatigue is another neurologic complication of Fabry disease. Not going to spend a lot of time on this, but it is a legitimate complaint. It is not just being depressed. It is not just being older. It's not just the idea that you have a chronic disease, because when we look at people with Fabry disease and compare them to other chronic diseases and to other people of the same age, they have more fatigue and more daytime sleepiness than they should, and the pattern is different than it is for other chronic diseases. GI is also the pain in the GI system, and to some extent the diarrhea in the GI that people with Fabry disease get is also thought to be neurologically mediated. And I'm not going to have time to go into that. We'll skip through this stuff. Okay. So kidney disease is still important, particularly for men, but also greatly elevated in women. Heart disease is the number one life-threatening complication of Fabry disease, the leading early cause of death for both sexes. And arrhythmias, this is focusing on females, but it's true for males. Also, arrhythmias are one of the leading life-threatening complications. It's not just heart failure. So if you are having runs of tachycardia, or if your heart is beating so slow that you have no energy, you need to talk to your cardiologist about that. Lymphedema is not a neurologic thing by any means, but it is a life-threatening complication of Fabry disease. And if you first notice that you're getting some swelling in your hands and feet, and you do something about it, you can keep it from becoming life-threatening. If you ignore it and wait until your ankles are so swollen that you can't buy shoes that fit, it's really hard to reverse that. So again, notice things early, deal with them early, you're going to get better outcomes. This is looking at quality of life. This is another one where it was easy to find the data in women because of recent publications. The data is similar for men, and across all of the subcategories of health-related quality of life, women with Fabry disease have decreased quality of life compared to the general population, and comparable quality of life to people with rheumatoid arthritis, diabetes, multiple sclerosis, etc. And yet nobody tells women with those other things that they don't need treatment. So don't let anybody tell you that because you're female, your disease isn't important. And if you are male, don't let the females in your family who have Fabry disease talk themselves out of getting the care that they need. So treatment initiation, earlier treatment tends to have more benefit. Now, we don't know exactly what is the best time to start treatment. Can it be done too early? Probably. especially for the non-classical Fabry disease, but we don't know what the best time is. If you have symptoms or if you have evidence of storage in your body from biopsies or blood tests, etc., it's probably a good time to start treatment. I would still like to see some prospective studies done looking at this issue so that we could define it better, but that hasn't been done yet. Each of the drug companies that has an FDA-approved drug is collecting some data that can help us to answer those questions. It just hasn't been enough yet to get a final answer. There are lots of things that go along with Fabry disease. It's just a list of symptoms, but these symptoms all have in common that there are non-Fabry targeted treatments for them. And I just want you to know that paying attention to the individual symptoms, getting those symptoms treated, will improve your outcome as long as that is also coupled with treatment of the underlying storage, which changes the physiology of your disease. So conclusions, we'll skip this one. And I think I used up all of my time. 3 minutes. Anybody have a question? Yes.
I have a question about, first of all, I'm going to go back to the babies. You mentioned that they really haven't noticed because they have no way of collecting information from the babies about whether or not they're having pain. But is there any sort of evidence that maybe those babies tend to be more fussy, like even maybe some sort of a survey with the parents?
The answer is yes. Don Laney did a study that was very important, in which instead of waiting until the patient complained or the family noticed, she found babies and had people fill out questionnaires on the babies and scored those, and found that it was very common for all of the babies to be more fussy, to have more diarrhea and GI symptoms, and to have fevers at times without evidence of an infection. So there is evidence that young children can have symptoms. The earliest, I think, was 8 months, which is pretty early. It might have been present before that, but it wasn't a big enough study, and the sensitivity of the questionnaires we used wasn't good enough to pick it up earlier than that.
The second one was in regards to the medications that are being used for treatment of nerve pain. One, it was in specifically low-dose naloxone. Has there been any evidence or any study or thought of trying to use that? I know it's used for a lot of autoimmune diseases.
I don't think that it has been used or studied in Fabry disease. One of the things that we have to pay a lot of attention to in Fabry disease that's different than the autoimmune diseases is the kidney health, because most people with Fabry disease have to worry about kidney health. So if a drug is metabolized through the kidneys, we try to avoid that. That's why the nonsteroidal anti-inflammatories are discouraged in Fabry disease. And so that would be something to look into.
We'll have the panel session. We have to stop the questions for now. We'll have the panel session. You'll get an opportunity to ask more questions when we get there. Thank you so much, Dr. Robb.